Hello, welcome to this special DIAPAT webinar dedicated to our handbook on special stains. It is my pleasure today to introduce Cristina D'Amico, product specialist at DIAPAT, who will briefly illustrate the project of this handbook that he has personally followed. And I will introduce Guy Orchard, who will talk about his chapter about recognizing and avoiding artifacts that represent a precious contribution to this handbook. Guy is head of laboratory at the well-known dermatological centre MOS within the Guy's and St Thomas Hospital in London. Guy is very experienced. He has won several international awards and recognitions as he's a technologist, manager, and teacher. Guy, in fact, is actively involved in teaching and training, both within the Guy's and St Thomas Trust framework, but also as an external lecturer at several universities in UK. Guy is an immunocytochemistry UK National External Quality Assurance Assessor, lecturer, and short course coordinator. He has been a council member for the Institute of Biomedical Science and is currently a specialist advisor for cellular pathology for the IBMS. In addition, Guy is now the chief examiner for cellular pathology for the IBMS. Guy sits on the Advanced Specialist Examination Co-Joint Boards for the IBMS and Royal College of Pathologists for histodissection, immunocytochemistry, and biomedical scientists reporting. Guy Orchard has published over 150 scientific papers and publications today. He's associate editor of the British Medical Journal of Biomedical Science and sits on 4 other editorial boards, as well as peer reviewing for several other journals. The book we are talking about today is not Guy Orchard's first book. Guy has edited and contributed to some Oxford University Press histopathology textbooks. Before we start listening to him, I would ask the audience to contribute questions. Any question is precious to us, and the speakers are more than happy to be given the opportunity to expand or clarify concepts. And now it is time to give the floor to Cristina D'Amico.
Good morning, everyone, and thank you, Dr. Savio, for the introduction. I am Cristina D'Amico, DIAPAT product specialist, and I oversee the special stains product line. And it has been my privilege to be involved in this important project to create a practical guide for the use of special stains. The Special Stains Handbook has been written by 19 authors. Each of them has contributed with their expertise in special stains, which is a subject that is not really well covered in textbooks or university courses. That's why this handbook is designed to be an educational tool for special stains. The first 2 introductory chapters of the book discuss the classification of stains for various tissue components and the chemical principles behind the staining. Then a wide range of special stains are deeply discussed, including their operating principles, reagents used, results, and providing images for interpretation. These images are crucial for understanding the staining outcomes. Dr. Guy Orchard has made a valuable contribution to the handbook, discussing a crucial topic, which are the staining artifacts, which can be found in chapter 3 of the book. I remind all of you that the handbook is available for free download on the DIAPAT website. And I would like to extend also my gratitude to Dr. Guy Orchard and all the other authors who have contributed to this project. I will leave now the word to Dr. Guy, and I hope you enjoy the webinar. Thank you.
Welcome, everybody, and thank you very much, Cristina, and also Danilo for all the hard work they have put in to prepare this webinar. I'd also like to say thank you very much for that very courteous introduction by Dr. Anatella Savio. Thank you, all of you. First of all, I should say ciao and buongiorno, hola and buenos dias for the Spanish-speaking people here, or buenas mananas. Portuguese, hola, bom dia. French, bonjour. German, hello and guten Morgen. That is the total limit of my linguistic skills, you'll be pleased to know. So we ought to start with the actual lecture itself, which is recognizing artifacts, staining demonstrations, and identifying it's a multifactorial problem. So the first thing to realize is that there are artifacts, and some of them are good, some of them are bad, and some of them are plain ugly. But you need to realize the difference and understand that pretty well much everything that we look at down a microscope is in fact an artifact of sorts. And there's the first statement. Everything we see under a microscope is an artifact, because the thing is that as soon as you take a piece of tissue out of the human body in the homeostatically moderated environment that is the human body, everything that happens to that tissue is basically a process of controlling the artifacts. We are able to do that quite effectively in modern day histopathology laboratories because we have standardized all our procedures, and we know what these artifacts look like and how to account for them in our assessments or our diagnostic appraisals. We know what shrinkage can look like, we know what contraction looks like, we know what all these other variables that come in to tissue processing look like, and we can standardize the procedure and therefore be able to understand the impact of these artifacts. So they're controlled artifacts. However, not all artifacts are controlled. There are some that are completely uncontrolled. And we need to know what these look like, how they're created, and most importantly, how to remedy them when we see them. So if you were to look at artifacts holistically, I think the most successful way of grouping them is to simply split them into two types. There are the pre-analytical artifacts. These are artifacts that occur outside of the laboratory framework. In other words, they're artifacts that we had no control over, that were produced in the clinical areas where the biopsies or tissues were taken, or in the clinics or the theatres or outpatients, wherever they may have been taken. These are pre-analytical artifacts. And then they're the ones that are related to what happens to that specimen as soon as we receive it in the laboratory. And we would classify that group as a post-analytical artifacts. And of course, within that category, you can subdivide a whole host of areas relating to the process and procedures that are specific to what happens to a biopsy as it moves through the laboratory. So specimen dissection, tissue processing, tissue embedding, microtomy, staining, and section mounting. That's a very broad categorization of the groups of areas that artifacts could be produced within the laboratory, but it is by no means exhaustive. So in terms of pre-analytical artifacts, well, you may think that there can't be too many of these, but in fact that there are quite a reasonable number, simply because fixation, which is the first step, we take a tissue out of the body. As soon as that happens, we are entering autolytic type processes. We have ruptured and severed capillaries and vessels and lymphatics, and cells are almost immediately releasing enzymes, which then causes autolytic change. And it's very, very important that the fixation process is prompt and swift. The smaller the specimen, the more important it is that the fixation takes place quickly. And in that process, we also could have tissue dehydration. So what could happen there is the biopsy is taken, it's left to the side while a form is filled out, for instance, or some necessary procedural step is followed before the tissue is placed in the fixed dip. Again, dehydrating the tissue, the smaller the tissue, the faster will that rate of dehydration take effect. Tissue fragmentation is quite obvious. As soon as you remove tissue, it can fragment. This is not desirable in most instances, and it's something that we need to be aware of and try to avoid in surgical procedures. Examples of this could be taking core biopsies from tissue that is highly friable and therefore more likely to fragment. This is a problem. We can get mechanical trauma, where the use of the surgical implements that we're using to remove the tissue actually causes damage to the tissue. If we think about forceps, we are squeezing tissue when we remove it. It causes leaching of enzymes from cells, and that causes damage. Heat damage can happen if we use cauterizing equipment in the theatres. This will singe tissue and burn it. Surgical nicks can be sometimes too large or too extensive. When we're marking for orientation in tissue, this can cause artifacts. Excessive marker inks that we use to show the profiles can infuse into the tissue and be obstructive to the assessment. And also excessively bloody specimens that are left to dry. The blood will dry on the sample and the specimen, and that itself can also be undesirable and cause artifacts. The key points about all of that is the importance of the communication between the clinical teams and the laboratory teams. There should be an appreciation of the turnaround times that are required and needed to be met for the investigations taking place. And also, there should be a comprehension of how to evaluate the tissue sample correctly. I classify that as what I would call good biopsy or good clinical practice. So in other words, the clinical staff know the type of biopsy they need to take for the investigations that you are going to perform on their behalf in the laboratory. So do you need a punch biopsy? Do you need an elliptical biopsy? Do you need a core biopsy? Which biopsy type do you need? Do you, in the case of, certain investigations of autoimmunity, where we're looking at blistering skin lesions, do we need lesional skin, peri-lesional skin as we call it, or do we need both? So again, understanding the requirements of the laboratory test is very important in the clinical setting. So that's what that's about. And then also an appreciation of the technical difficulties that the laboratory is going to face given the sample that they have received. And I think we tend to not realize this can be such a problem. Examples again would include core biopsies where they haven't really sampled the most appropriate area, therefore the diagnostic material available is limited and may in some way be damaged by the process. An example could also be acantholytic squamous cell carcinomas, where we have a very crusty surface. It's very important in such cases that tissue is taken deeper below the crusty material, which is essentially keratin, and is not going to be useful in a diagnostic setting. So these are examples of the communication, the understanding that should exist in a clinical practice and setting, and also in the laboratory for what they need to do to optimize the investigations that they can give you to help a diagnosis being made. So I need to talk a little bit about internal and external quality assurance, IQC and EQA. I'm sure in all your various countries, many of you will have similar terms. So I think it's important to define this. The internal quality assurance defines the acceptable level of staining, and it's governed by the understanding of a series of important evaluations: reagent management, equipment validation, staff competencies, and also the effectiveness of the standard operating procedures that you're following. In effect, those 4 or 5 categories I've listed there are your tools to try and govern and control artifacts occurring within the laboratory. External quality assurance defines the standards that we expect nationally across the entire country or continent in many cases. It helps to monitor trends. It will help to define working practices. It aims to inform us and educate us on what is best practice. So this is important as well, and is often a guide to how well you're doing things and how you're monitoring and controlling artifacts. Finally, on the coat of the arms of the IBMS, and you've already been informed I'm the current chief examiner for cellular pathology, so this is almost tattooed on my arm. So disset et proficius, which means, it's a Latin phrase and means learn that you may improve, and it's emblazed on the coat of arms of the Institute of Biomedical Science, and it is a very important and a valuable phrase to remember. So, as I said to you in the last slide, quality indicators are key. We can look at how we can control artifacts by considering 4 main areas. We'll go through each of these in turn, and I'll give you some indicators of what things need to be considered in each category. So, reagent management, tracking and auditing of your reagents that you're using for your staining and processing procedures. Equipment validation is all about service records that you hold for equipment and making sure they're maintained and updated and audited on a regular basis. The third one, I believe, is probably one of the most important aspects, and probably the one that we tend to push to one side because time is precious and we don't have the resource necessarily to look at training our staff to the degree that we should, to reduce human error, because the more the training is conducted and the better the training is conducted, the more confident the staff feel and the more educated they are in understanding what they're doing. So training is incredibly important, and wrapped up with that is also staff competencies. How do you know a staff member is competent if they follow an SOP but don't understand it? Simple analogy, but one that is very important. And then there is the SOPs, and I can tell you there are good SOPs and there are bad SOPs, and I've read all types. The important thing to remember about operating procedures, they are just words on a page. The important thing is the comprehension and the understanding of those words on that page. And I've seen it in practice, and I carried out little tests to prove my point, where I've given SOPs to 2 competent individuals, who I regarded as competent, with a string of 15, 16 operative steps. And I can guarantee you, with timelines for each step, I can guarantee you they wouldn't do or follow the procedure in exactly the same way, because we're all human, we're not robots, and we don't do things exactly in the same way. That is human nature, but the cumulative effect of not following things in a standardized way could in fact create unwanted artifacts. So let's look at reagent management. What are the kind of things that you need to do to avoid artifacts which relate to the reagents that you're using? I think it's important to have reagent and batch lot checks. This is now commonplace in most laboratories that follow UCAS standards. So this is where you check your reagents as soon as they arrive. You check the batches to make sure that there's consistency across the batch. And that is done ideally before you even use those reagents in a diagnostic setting. Expiry dates are common to all of us. We only have to go to the supermarket and buy any food, and there are dates all over them stating when is the best date to consume these products in a supermarket setting. But it also applies, of course, to the laboratory in terms of how the dates of which the reagents are valid and when they should be discarded or expired. Stock solutions and validation, these are to do with perhaps understanding working solutions, so not from the batch, but then you make up a working solution. How is that done? How is that checked? How is that validated? Do we use controls that are appropriate each time? Tracking and usage and replacement of procedures. So whenever we change a procedure, how do we track that procedure? How do we ensure that that information is available to all that conduct those procedures? And how do we ensure we are tracking and monitoring it? And also, the whole purpose of all of those 4 items is to monitor and track them throughout audit checks, to make sure they're all being followed and to make sure that we're not missing some key areas which could produce more artifacts. In terms of equipment, how do we validate new equipment? How do we verify equipment? And that also includes what we do when we've had a service visit and something's been repaired, but before we put the machine back into operation, have we checked that it actually is doing what it's supposed to be doing? So this is important in how we verify and validate equipment. how we monitor and maintain records. This includes temperature ranges of fridges and ovens. Very important, because those temperature changes can have a significant impact on a whole host of artifacts that can be created if they're not within the defined ranges. Error logging and tracking faults. What we're doing here, by logging our faults that we recognize, which we're trying to map a trend. It could be we can identify a certain piece of kit which keeps having a particular fault, and this is the basis of how you build up evidence to replace that piece of kit, how you will build up evidence to have a business case to buy a replacement piece of machinery. So error logging is very important in this context. It's also important for staff safety. Very important to understand that if something's not working properly, are the staff that are using that equipment safe? Are they being protected appropriately? Important. In my book, every key piece of equipment you have in any laboratory should have a backup. So there should be a spare available should anything go wrong with any key piece of equipment. You should also have access to service engineer agreements and ensure that the standard of engineering support that you're getting in terms of a service contract is adequate and fit for purpose. Staff competencies. I've said to you this is crucial. I believe it's the weakest point that we can have problems, because we do our best to offer training, but do we do enough? That's the question. There should be adequate evidence of regular competency checks of our staff, and these should be recorded so we can track how staff are doing. If they're having difficulties with any specific procedure, they need help and support, and they need to be encouraged to learn and improve. So on the coat of arms. Options to ensure training is expansive and encompasses new developments. We are in the UK embarking on quite a number of initiatives where we're trying to encourage the biomedical science staff not just to work in their confined areas within the laboratory, but to try and develop specialist advanced skills in histological dissection, and now more recently reporting. So this is a new area in the UK. It's being explored and is something which will only increase the horizons for those that work within the laboratory. And finally, I put on this one, research and development. I'm very keen in my establishment here that all my staff, as many as possible, can get involved in research and development. How on earth do you improve in your technology and your skills if you don't do research and development? It's a bit like being in a silo where you're not able to lift the lid. You need to lift the lid, and you need to be able to do things that enable you to improve, because those research and development techniques that you're doing will end up being diagnostic tests in the future. SOPs. I told you there are good SOPs and there are bad SOPs, and this picture on the right really tries to depict the two faces of that. I've read SOPs that are very, very lengthy, but don't actually tell you the key information that you need to know in order to do a procedure correctly. I've seen and read SOPs that are a page long, but they're perfect because they're absolutely targeted on what they're supposed to be delivering. So the devil is in the detail. What is relevant, what is not relevant in an SOP procedure. There should be also a key area and attention to health and safety issues for those that are practicing them. These SOPs should be reviewed every year. Any changes made to those SOPs should be captured, logged, and audited. The point here is that no SOP is ever a static SOP. Things are always changing, and this must be captured. A more recent example of this is what's happened in Ukraine with all the war situation. A lot of raw products we use in our dye industry was coming out of Ukraine, and suddenly there was lots of problems with accessing raw materials, and so alternatives were sought. So you can quickly see how that might impact on a staining procedure or an outcome, because you're changing the key ingredients of what you're using. You're sourcing alternatives. It's very important to review SOPs in the light of things like that. Now I'm just going to go through a gallery of artifacts. I'm going to show you some things so you understand and know what they look like. Here's an example then of the heat artifact that we discussed at the beginning. This could be that a tissue has been either heated by cauterizing the edge of the sample and it's dried out, and you get this rather stellate looking appearance to the nuclei where they're elongated. The staining is not correct in this H&E, it's too blue, and overall you can see that does not appear to be in any way a normal appearance for a piece of tissue that would otherwise appear quite different in staining outcome and also preservation of the morphological detail. Here we see the drying out artifact where the tissue has just been smothered with blood and it's dried to create an obscure mask, if you will, over the areas. That could be key in certain assessment criteria, and we need to be able to see through that. So this is drying artifact as a result of blood on the tissue. You also actually, I should go back, you also have evidence there of ink infusion. Ink is applied to the outer edges of a sample. It shouldn't really be in the middle. So the reason it's got there is it's followed a fissure or a split in the tissue and has wound up reaching the mid portion of the sample where it's not really supposed to be. Here is a good example of the crushing artifact, which can be due to the use of forceps in the theatres or the clinics, because what's happened here, this is a cutaneous T-cell lymphoma and it's an H&E preparation, and you can see on the right and a little bit on the left and also at the top there appears to be sort of lytic looking areas of stellate looking very blue staining cells. These are cells that have been ruptured. They would all be these rather small round cells, as you can see more on the left, but they've burst open because of the pinching or squeezing of the forceps as this biopsy was removed from the patient, and because it is a very cellular tumor, the cells have burst open and the enzymes are being released, and essentially when you do immunocytochemistry on something like this, a lot of antigenicity is lost because of all that lytic change that you're seeing in the H&E. This is no prizes for guessing what this is about. Focal calcification in tissues can cause all kinds of artifacts, and when the blade hits a lump of calcium, albeit small, it invariably blunts the blade and you get a shattered knife mark effect directly following that impact, and the knife is therefore blunt at that point, which should be changed. Focal calcification is quite a common thing in lots of tissue types like prostate, but also in skin, in tumours like basal cell carcinomas. It's quite a common finding. This is an interesting one. It's a PES stain this time, and here we see streaming artifact. And what I'm trying to show here is that glycogen deposits within certain tissues, namely the liver, but also in mucosal sites such as the lips, has a distribution of glycogen that goes throughout the entire cell cytoplasm, as you can see on the left there. But what happens when the formalin is put into cells that are highly rich in glycogen? It sweeps the glycogen to one side of the cell, and we call this streaming artifact. So you can see that on the right, where the glycogen has been swept to one side of the cell, indicating where the flow of the formalin into the tissue has taken place. It's an artifact. We know what it looks like. We can account for it. And this is an interesting one. This one is an H&E in a toluidine blue. And what I'm trying to show you here is Demodex mites. Now, they exist in many of us. Normally, we have two types of Demodex mite in our skin, either a folliculorum or a brevis. In cross-section, they look a little bit like what you can see there on the left. These are Demodex mites in cross-section. And I was very fortunate fairly recently to observe a whole Demodex mite in the toluidine blue preparation on your right, and you can actually see the mouth parts at the end, its legs sticking out in the abdomen area, and if you look very carefully right at the end, you can actually see almost like a fish tail, because they have a fishy little tail at the end which they use to sweep as they munch through the sebum within your hair follicles. So you're probably all itching at this point, but anyway, I'm going to carry on with the talk. Starch grains. Starch grains are very commonly found in surgical gloves, and starch grains, if they fall onto tissue, because they are a carbohydrate, would stain with PAS, for instance, and then you can see it staining there on the left, starch grains on a tissue section from the surgical gloves. Hasn't washed off and is PAS positive. Interestingly, if you use photographic light equipment, notably a cross polarizer, starch grains have a very characteristic Maltese cross appearance to them, and you can see that on the right there, the Maltese cross of the starch grains. This is a common artifact. We call these squames. They are basically the anucleated cornified layer of skin that flakes off everybody 24 hours a day, and these cells are anucleated at this stage, and they're just dead squames, and they flake off. But if they happen to fall on tissue sections, either in the water bath, when you're cutting and mounting the tissue on a slide, or in fact following staining, then they would appear to be very eosinophilic in an H&E stain and are therefore undesirable. And some people, of course, have dermatological conditions where they desquamate at a fairly high rate, and that can be a problem in terms of this particular artifact. Cholesterol clefts, common finding in very granulomatous type reactions in tissue, and cholesterol is not soluble in alcohols, and so therefore during tissue processing the cholesterol dissolves and you're left with cleft-like marks, as you can see here in this H&E preparation. Classic example of cholesterol clefts. More simplistically, we're looking at a Hales colloidal iron here, and the important point here is the importance of section thickness and how that can create artifacts. So on the left we have a rather thick section where the morphological features of the cells are masked by the sheer thickness of the section. The reason here being resolution is impacted because the light that we pass through the section is not getting through to the high enough degree for us to actually see the details of the cells in any great capacity. On the left, we have on the right rather, we have a much better preparation of a thinner section, and the morphological detail you can ascertain from that is far greater than what you can see on the left. So that's about thickness and thin sections and how important that is in terms of identification of morphological detail. Here we have a Grocott stain, which is wrong on two counts really. Firstly, the intensity of the silver staining in this particular preparation is below par, mainly because it hasn't been incubated long enough within the silver solution to demonstrate the fungi effectively. You can see it, but it should be a lot darker than this. Similarly, you can also just about work out the septae between the fungal walls, which I always like to see in a good Grocott stain, but again it's a bit pale. More concerning is the counter stain, which normally is a light green, not in everybody's lab, but in most labs it's light green, and that is almost too pale to be able to see what the tissue morphology is like underneath these fungal hyphae. So wrong on two counts there. Attention to detail on the SOP, longer incubation in the silver solution, and certainly longer incubation with the counter stain. Poor dehydration creates artifacts in tissue sections when we process and stain them, and you can see here it has this translucent effect. That's very important if you're looking for margin clearance. We can't really see what's going on in this tissue on the edge, and that is hindering the staining and also not very clear morphological detail. So that section needs to be dehydrated and restained. Freezing artifact, well, we all know what that looks like. It causes tears and rips in tissue which is high in water content, and invariably this is the adipocytes and the fat cells we have within the deeper layers of our skin and within breast tissue. That was a frozen section. Here we see it in a formally fixed paraffin embedded tissue section in the investigation of tumor clearance in a tumor which invades deep into the fat called a dermatofibrosarcoma protuberans. The point being here, if you have holes in the tissue, you cannot be sure that you're able to demonstrate full clearance of a tumor because there are holes there. So it's difficult to know whether tumour was in that area or not. So good processing is very important in ensuring that we get to see the entire tissue section. Here's another one showing overstaining. We saw that with the Hales colloidal iron, but this time the issue is more about a thick section which is overstaining with hematoxylin and also is not differentiated out, so the eosin is also looking rather odd in color. But more worrying is the tissue pieces that are flaking off this section, and that in itself can cause quite a lot of problems, because if you're batch staining, some of these flakes could contain tumor. That tumor could adhere to another case, a different slide of a different patient, and you could end up with a misdiagnosis based on lifting and fragmenting of tissue and transfer onto unrelated patient material with subsequent consequences for surgical treatment. That is in the literature, it has happened, and therefore we need to be very clear about procedures we adopt in terms of ensuring tissue fragmentation is minimized. Here we see precipitation staining reactions in toluidine blue stains. You can see a number of crystalloid-like structures. This is the importance of filtering dyes before we use them, especially if they're not used on a regular basis. Oxidation occurs and crystalline formation will result. Filtering it removes them prior to staining. Again, here in an H&E, also those are the crystalloid structures, but you can also see tearing and trimming artifact within that tumor deposit of a basal cell carcinoma, where there are holes appearing, so that the block needed to be trimmed a little bit more smoothly to avoid trimming artifact, as well as the staining with crystalloid structure formation. Some dyes and stains we don't use very often, and we leave them on the side. We then may not have a period where it's warmer in the laboratory. Some of you come from hot climates. This is a bigger problem for you, because fungal growths and bacterial growths will occur everywhere. And in stationary solutions, they will grow. If the environment is correct, they will grow. And here we see an example of fungal hyphae in a toluidine blue staining solution that is transferred onto the tissue section. Air bubble artifacts are a staggeringly common problem. You may think it's not a big deal, but it is, because you can't really see what's underneath the bubble. And if you have a number of these bubbles, it causes quite a lot of problems in interpretation. So air bubble formation is a big problem in probably most laboratories throughout the world, but you need to be very attentive to how you cover slip such material and make sure that the mounting medium you're using is adequate in volume to reduce this effect. Oh dear, poor cover slipping. So if you're looking at a margin and the cover slip has moved and that section has dried out, you could end up with a horror story. Well, we are nearly at the Halloween point, so yes, quite appropriate, where the tissue appears to be completely uninterpretable on the right of that tissue section. This one is what I call the spring effect. So here we have a coiled hair fallen off of somebody's head onto a tissue section, mounted, applied. You can actually see the hair bulb at the bottom of that coiled hair, and that is acting like a spring under the cover slip and is pushing the cover slip up and therefore creating a bubble effect. So in summary then, I'd like to finish with a couple of points. Tissue artifacts can be introduced into tissue samples during any number of steps, and therefore these steps could carry through before you assess it under the microscope. So poor handling of tissue along with prompt fixation and careful tissue processing will reduce the impact of a number of these artifacts that I've shown you today. What's important is that there is a comprehensive understanding of what these artifacts look like. Again, I hope I've shown you many, both macroscopically but also microscopically, to ensure that we are able to minimize their impact microscopically. An understanding of how to eliminate their potential impact to effective outcomes is also an important understanding, and remedies will minimize the risk of misinterpretation and difficulties encountered in any diagnostic assessment. The point being, please remember the key areas: reagent management, tissue equipment validations, SOPs and staff competencies is key, and also quality assurance assessments and how you keep up to date with how you monitor trends. All important in maintaining and monitoring the production of artifacts in a laboratory setting. Finally, it's all about teamwork. Teamwork both within the laboratory, teamwork within clinical setting, ideally both. Communication between those teams to ensure you optimize the samples that you're taking for the use and the diagnostic purpose to help and aid patient treatment. Here, I'd like to acknowledge many of my staff, and in fact, there's Christina in the middle of that one, in the gardens, St. Thomas's, a few years ago now. So these are not all my staff, but there are ones I have to hand with the photographs to show, and there in fact is the reporting room at St. Thomas's where we reside, and that's the view we have of the Houses of Parliament outside the window. So I'd like to say thank you to all of them for everything that they do to help improve our quality and our output in terms of controlling artifacts within the laboratory. Thank you for your attention. These are the reference sources I have used for today, so please feel free to look at any of those if you so wish. And thank you.
Okay, thank you, Guy, for your very interesting presentation, and thank you, Christina, for introducing the topic. Now it is time for the question and answer session, but I don't see any question still from the audience. So to break the ice, I will start with a few questions myself. So Guy, in your opinion, who is the ideal user of this handbook on special stains?
I hope you can all hear me. Well, the handbook, and we haven't done this, but here's a picture of it. Look, here we go. We do this, there we go. There it is. That's the book. All of you, if you haven't seen it, but that's it. So the ideal user, well, it was written, I guess, mainly for laboratory personnel, which is, I would imagine, the larger number of people who are listening. But of course, it has a value not only to those that are performing staining techniques and histological investigations, but also those that have to report them. So that includes the pathologists as well, because they need to recognize what artifacts look like in order to understand that there is a problem here, or with any given artifact, where did it come from, and understand the process just as much as the laboratory does. So I think it has appeal for both pathologists and also biomedical scientists. And I'd like to think that medical students, as well as biomedical students that aren't yet in the laboratories or in the clinical setting, are also, but maybe have an inkling that they're keen on pathology, would start picking up on some of these factors, because they do encompass all areas of histological investigation, as I hope I was able to demonstrate in my talk. So I think that's the important thing. It isn't niche in that sense. It is quite far-reaching. So I hope other groups, including clinical staff, who perhaps don't do histology, like the clinicians who provide us with the biopsies, to start understanding what they need to be doing to avoid the pre-analytical artifacts that they could create in a clinical setting.
Yeah. Yes, I agree. But I think your chapter about recognizing and fixing artifacts is really important to this book and fundamental. And I suppose that the decision to add this chapter comes from your practical experience. Could you give us some examples where the recognition of an artifact was crucial for a diagnosis?
Right, yes, well, I can give you several examples, but I guess I'll try and pick on the ones that happened more recently, because we had a fascinating case in our Mohs surgery unit where we were doing a frozen section assessment of a lady who had, and we didn't know it at the time, but she had cystinosis. And this is a crystalloid deposits that build up in the tissues, and she was having a BCC removed from her face, and we were seeing all these crystals suddenly, oblong crystals appearing within the tissue, and we were quite perplexed as to what that was, or the initial thought was it was something we had created inadvertently in the laboratory, something wrong with the DPX perhaps, or some aspect of the staining. But they were quite distinctive crystalloid, rhomboid shaped crystals. And it wasn't until we read further into her case history that we found out she had quite serious renal disease, and that she had underlying cystinosis, which would explain, in fact, why these crystalloid structures were found within her skin. So there's a classic example of a bit of a mystery involving what was the cause of this lady's crystalline deposits within her skin sample. So that was a good example there. But there are many others that you can think of. I did touch on issues of tissue fragmentation and detachment, and it's well written up in the literature that these can lead, especially in staining procedures where tissue fragments fall off slides and then attach to other slides in a batch that you may be staining, and the end result is that those fragments could contain tumor of some description. And if the query is similar, just coincidentally, you might think a person who has breast cancer genuinely, but has detached fragments that attach to another person who was queried having breast cancer. It does look like breast cancer, and all of a sudden you have a potential amputation of a person's breast, which may not be actually required because of that issue. And that's what's actually happened in 1 or 2 cases in the literature. So I think that's another example then, where the consequences of attention to detail in terms of avoiding these sort of issues had significant consequences.
Thanks a lot. It is very important to know the real importance. There is a message from Amadeo Ferro. Okay, hello Guy, Amadeo from Portugal here. Fantastic lecture. I would like to ask you some suggestions in order to facilitate the communication between the surgery room and the lab. Many thanks.
Okay, so I think this is not a sophisticated problem. I think it is just a desire to build up a wavelength between the clinical practicing aspects of removal of tissues and the laboratory requirement to deliver what they would like in terms of a valuable report that you're going to generate for them to help them treat the patient. So I think it's really all about ensuring the practices that they adopt, and this doesn't just encompass the type of biopsy they're going to take or the tissue sample they're going to remove. It encompasses everything from the pots they're using to put the fixatives in. Has it got adequate fixative? Simple one, you all know that you need to be putting any sample in 20 times its volume of formalin. I can tell you 50% of the time that never happens. It gets ridiculous when you get a lump size, tennis ball size piece of tissue squeezed into a jar that is only perhaps twice the size of the tennis ball. So you've only got double the volume, not 20 times the volume. And then they'll wonder why they don't get the report quickly, because it hasn't been fixed. Well, it won't be, because it needs to be opened up and all these factors need to be understood. So really, it's about education, isn't it? It's about education, it's about understanding, it's about talking to the clinical teams to try to say, don't really, this would be better for you if you did it like this. And once they see the benefits, invariably in my experience, they run with it, because they can see the benefits to the service and the speed that they get the results back. So in a nutshell, Amadeus, is actually about communication, it's actually about talking, it's actually about reassuring and actually sending emails. Thanks for a very good biopsy on that case. That was excellent, really good depth to the biopsy, showed a lot of detail. We had everything we needed from that, just as much as it is about criticizing when somebody does it wrong. For instance, take an alopecia biopsy. I get a number of them. They're not deep enough. They're not gone down deep enough. They haven't got the hair bulb. A lot of pathologies residing around the hair bulbs. If you have a shallow biopsy, you've cut half the issue away because you can't give a definitive diagnosis because you can't see the detail. So it's things like that need to be communicated. And whatever medium you use, but I find it best just simply to talk to people, then it's probably a good way of doing it. Sometimes we do seminars, little talks, little lectures like this, I guess, and try to communicate those details, those small attentive details, to give people an understanding. And then once they understand it, they're normally very happy to oblige. That's been my experience anyway.
Yeah, to contribute to the final result, because in fact they contribute. Even the time between the sampling and the specimen is brought to the lab is important, so they have to know that. Okay, so I will go on with another question. Are there, we have been talking about artifacts on special stains, but are there additional specific artifacts linked to digital or molecular pathology?
Absolutely. And I guess the answer to the molecular one is one that we probably are reasonably aware of, because molecular pathology is really very much reliant on appropriate and adequate and not excessive. It's the other way. Well, you can underdoing fixation for molecular techniques is probably not necessarily a bad thing, but certainly overfixing them tissue is a bad thing, because fixation will modify and damage the DNA to some extent, and this then interferes with the sequencing processes that the biopsy would then cause. The curls that you produce from the paraffin block would be it would interfere with that sequencing process, and it could result in them not being able to amplify the DNA, and therefore you could have taken 50, 60, 70 microns worth of DNA off a block, which is a sizable amount, and actually not got a result from that because you were unable to amplify the DNA. So I think these attention to details with molecular techniques are still very much at the forefront, and we're doing more and more of them because the sensitivity to the molecular assays is getting increasingly sophisticated. We're now on next generation sequencing and multiplexing technology, and it really is important that attention to detail is applied when we're dealing with the fixation, particularly the fixation part of material. We will likely require molecular testing of some description. I think that's the main problem with molecular. Digital pathology, well, we're all just about embarking on all of that now. Some of us are a bit more advanced than others, but the issues around digital pathology, it's a different kettle of fish. Sorry, that's a very English term. I don't know whether that equates in Italy, but it's a different kettle of fish in the sense that we are now looking at images, pictures in effect, rather than slides that we look down a microscope with. And indeed, these images are going to be spread around computers. They will have requirements around color, that we know how important the staining outcome in terms of the color and the contrast and the depth of staining that we get when we look down a microscope. You know, it remains to be seen how skillfully reproducible they are in a digitalized image. We also may project it to our colleagues in America or Spain for a second opinion. And do we know that the image capture and the image quality is going to be the same as what we're looking at our end compared to what they're looking at their end? So those are the dilemmas that need to be worked through and standardized. But on top of that, we've still got the same problems like folds, creases, dust that gets onto lenses that we're photographing, and then you can see that transmitted into an image picture. We can get inks, marker dyes that we've used to show an arrow that could be marking cells and covering up detail. All those things still apply to digital, and indeed as does cover slipping and you know, XF mounted that catches around the slides and messes up the image capture or the camera facility. So all of that is important. And then finally, scanning. You know, how effective, how fast, how efficient is the scanning ability of the digital system that you're uploading. So that is just a little overview, but I'm probably by no means exhausting the issue, because the networking aspect is also not straightforward, and you need to be talking on the same systems to be confident about what you're all looking at.
Okay, so I will use some of the questions raised by the audience during the previous webinar. What is your opinion on using AI for artifact identification and of its use in tissue diagnostics?
So AI is a very important and up-and-coming technology that will definitely impact in cellular tissue science diagnostically, probably also in a significant capacity in terms of research. So the ability to use AI as a learning tool is only going to be as good as the technology and the skill of those that are programming it and inputting the software that it employs to analyze the tissue. And in most cases, the AI programs are built around experts in the field that are well known for their skill and expertise. So these are pathologists invariably who are experts in melanoma, for instance, or breast cancer, and they would build the algorithms that they use to teach and learn the program that is the AI program. And every time they would perhaps see the results, agree that they are correct or not, change the software so that software learns, if you will, from that experience and improves. So it's getting better and better because it's learning the subtleties of the diagnostic setting. So, and I gather from the papers that I've written, and I'm not extensively read here, but I have read a few, that they are incredibly accurate, some of these systems. They are getting consistently good results, and they're beginning to roll them out into several spheres of diagnostic settings. So I think they're here to stay. I think they're going to be an integral part of what we do. Some people may worry about that, but we have a decreasing number of pathologists available to us. We will have to look at tools of this nature to enable us to deal with workloads, and also we will have to look at skills for some of our biomedical science staff that may have to or be encouraged to help out in some capacity with some of this workload. This is the future. I think it will probably manifest itself in some degree and some form in that way. The other part of the question, I think, was AI good to identifying artifacts? Well, the probability is it would know it's foreign because it's not something it's programmed to read. It will read it as something alien, and it will flag it. So therefore, it will pick up that this is not something that is in my algorithm to identify what is it. It'll probably ask that question of its programmers, in which case they will provide that input and the program software will learn from that. I think artifacts in some cases are a question of learning to accept the unexpected, because that is the true nature of some of these artifacts. You see them, they completely were unexpected, but yet they're there. So you do, it's not something you can think, oh yeah, that's normal. Quite often it isn't. I think that's the philosophical way of looking at it.
Yeah. So can you get artifact mechanical damage, for example, from excessive use of tissue dampers at embedding?
Yeah, so there's no reason to suggest that you can't. The only thing with the specific question of tissue dampers is that you usually apply those to push tissue down so that you can ensure you're going to get a full face when you cut the block. And the dampers are applied to the top of the block, not the cutting face, not the cutting face. So for that to be the case, that you're unlikely to sample tissue from the back of the block, because it's only on the top that you're applying the damper. So I wouldn't think it's going to be necessarily a problem, but it is a transferable risk that you could, from one specimen to another, where you use the same damper, transfer a tissue. You should of course be wiping such equipment down between the various blocks that you're embedding. So the same applies to the forceps that you use in embedding, that you change those and clean those between blocks.
Okay, so thank you for your giving us a glimpse of your expertise, and for showing us all this good information and advices. And I think there are no more questions now, so we can now finish this webinar. I thank you, thank Christina, and thank the audience. And look at the handbook.
There we are.
Okay, here it is. Thank you, Guy.
No, pleasure.
Bye.
Cheerio. Cheerio, everybody. Nice to have spoken to you. Take care. Bye-bye.
Thank you. Bye.